Bismillah ar-Rahman ar-Rahim. Welcome, dear all, for our third episode for Nephropathology lectures by Associate Professor of Pathology, Dr. Sarah Hassan. This lecture will be about podocytopathies and how podocytopathies can help in diagnosis of different pathologies in nephrology. I'm sure that we will enjoy the lecture as we did in the previous two episodes. Please, Dr. Sarah.
Assalamu alaikum wa rahmatullah. Let's talk today about the topic of podocytopathies. I think it's one of the interesting topics that is always have updates. So let's start.
Sarah?
First, podocytopathies could be Dr. Hamad?
Yes, I can hear you now, yes.
Okay. We can present podocytopathies as two famous ins, minimal change disease and focal segmental glomerulosclerosis. Two rare subtypes could be put under the title of podocytopathies, which is diffuse mesangial sclerosis of the infantile nephrotic syndrome, as well as collapsing glomerulopathies, which are usually put under focal segmental glomerulosclerosis subtypes. But let us now consider minimal change disease and focal segmental glomerulosclerosis as the two ends of the spectrum of podocytopathies. Pathogenesis of podocytopathies, some evidence supports that these two entities are two manifestations of a similar disease. However, other evidences support that they are totally different. And I think that every day concept is added to these diseases or this pattern of glomerular injury. Especially after the introduction of the next generation sequencing techniques in the routine diagnosis of these. Mainly, what we know till now is the abnormal glomerular growth, which is and the adaptation of the glomerulus as a starting point for the development of focal segmental glomerulosclerosis. And podocytopathies is another phase for what is known as effacement, which is mainly or only diagnosed or only seen by electron microscope, which means the loss of the podocytes food processes pattern that we all know as seen here in the inset, and becomes only this continuous cytoplasmic sheet, which is known as or defined as effacement, as we have previously said in the last two lectures, mainly in the first lecture. So this term or this pattern is only seen by electron microscope. Another feature of podocytopathies, but it's not a diagnostic feature, but commonly seen with any injury of podocytes, is a loss or detachment of podocytes, which means that the podocyte here is totally not attached to the underlying glomerular basement membrane. I hope that this picture is clear for the detached podocyte. Mainly the detached nucleus of podocyte, or the detached head of the podocyte. And the microvillus transformation, which means that the podocytes has many microvilli like that of the intestine that are projecting into the urinary pole. What is minimal change disease? Minimal change disease is simply under light microscope is a no change under light microscope. So the glomerulus is totally free and the rest of the compartments are normal. Tubules, interstitium, and vessels, everything is normal. So no change under light microscope. On the other hand, what is focal segmental glomerulosclerosis? Let's define it. define focal segmental glomerulosclerosis. Focal segmental glomerulosclerosis is a light microscopic diagnosis or a light microscopic description of the pattern of scarring in even one glomerulus. So it is focal and segmental and even one glomerulus, not a globally sclerosed glomerulus. And it is described as obliteration of capillary loops and increase in mesangial matrix and adhesion to Bowman capsule can also be seen. Let's see this in this picture. Can anyone describe what is in this light microscopic picture? Any ideas?
You can write in the chat in the chat box. Do you see any adhesions? Do you see an increase in the mesangial matrix?
By the way, this is a serial, and this is the next serial for the same glomerulus of the same patient. So in this patient, this glomerulus, we see what?
We can
We'd
ask
like to
what is the arrow is pointing for. If you can write in the
yes.
chat
What is
box,
that?
yes.
Yeah.
We have answers: focal sclerosis. What exactly
Okay.
the arrow is pointing for?
We can go to the previous slide, and we said that we can see obliteration of the capillary loops, increase in mesangial matrix, adhesions to the Bowman capsule. Is an MCQ question, and this is the choices. These are the choices. It's an obliteration of the capillary loops, increase in mesangial matrix, or adhesion to the Bowman capsule
We
in
have
this picture.
some answers for adhesion.
Adhesions, right? That's obviously an adhesion, and that's the Bowman capsule. Okay, let's see the serial cut for the same glomerulus. Can we choose another choice? Is it an obliteration of the glomerular capillaries? Adhesions are also present, of course, but what else was introduced to the same picture?
The answers between obliteration, scarring, and sclerosis.
Obliteration, scarring, and sclerosis. Okay, yeah. Yeah, yeah, the same for these capillaries are now obliterated, are not any more patent. If we compare this patent, capillary lumen is absent here, and we see like something like a collapsed membrane over itself. So it's an obliterated capillary lumen, which is here is called the focal segmental glomerulosclerosis pattern of injury with adhesions. Okay. In this picture, the double-headed arrows points for what? Again, which of the choices? Is it adhesion to the Bowman capsule, obliteration of a capillary lumen, or an increase in mesangial matrix?
We are waiting for the answers. We have increase in mesangial matrix.
Yes, it's an increase of mesangial matrix, which is a cellular without cellularity. Besides, if you can see here, that's the hilar inlet of the glomerulus. This hilar inlet here has a wide base, which could be also called perihilar sclerosis, because the hilar inlet shouldn't be that wide.
Sarah,
Okay, here again.
how did you recognize this as a hilum? What are the criteria in this slide that you determined it as a hilum?
most probably this is an inhaler inlet with an afferent or inferior arteriole entering to the glomerulus. Besides,
can you point to the arteriole?
I think that's it.
Okay.
But let me show you another one which is more evident.
Okay.
The inlet here is more evident, Dr. Muhammad.
Yes,
It's a more evident
yes.
inlet.
Here it is clear. Yes.
Oh, that's more clear. Here the inlet is not evident. So not all serial cuts show us an obvious inlet, okay? And if you are in doubt, just follow the serial sections. Am I clear?
Yes, clear.
Okay. Another picture showing an increase in the mesangial matrix. Okay. So now we have said two concepts. The first is that focal segmental glomerulosclerosis is a light microscopic description, and we have seen together multiple light microscopic pictures that showed us the description and the definition of what is called focal segmental glomerulosclerosis. But on the other hand, we said that effacement is only seen by electron microscope and that effacement is diagnostic for podocytopathies. So, which is the right concept? Is it is a light microscopic diagnosis? Focal segmental is a light microscopic diagnosis, or we have to do electron microscope to diagnose it? Simply, podocytopathies, let's start from the beginning. For a nephrotic syndrome, both minimal change disease and focal segmental glomerulosclerosis may overlap clinically. So we cannot differentiate clinically between minimal change and focal segmental glomerulosclerosis. Of course, in children, in a nephrotic kid, the first differential diagnosis is minimal change disease, and most of the time, the renal biopsy is not done and is taken only for steroid resistant and unresponsive cases. And it accounts in adult for a percentage of from 10 to 15%. And the incidence of focal segmental glomerulosclerosis is increasing worldwide. And renal biopsy is essential in diagnosing nephrotic syndrome in adults, unlike children. But the prognosis between both is different, with hope of recovery in minimal change disease and fear of regression in focal segmental glomerulosclerosis. So we should differentiate. For a nephrologist, his role is to pick or enough sample, enough biopsy that includes a juxtamedullary glomeruli, where we used to say that focal segmental glomerulosclerosis starts in these glomeruli, the glomeruli that are near to the medulla. And you should give us full clinical details about the mode of onset, history of intake of the drug intake, which is very important to know if the patient start immunosuppressive therapy or not. And in the next slides, we will say why I should know that the patient started immunosuppressive therapies or not. For a pathologist or a nephropathologist has another role to pick up focal segmental glomerulosclerosis. First, we should do multiple serial sections. As you have seen in the picture, every serial is a picture of the serial sections of the same glomerulus. Every serial shows a new information. Here's an adhesion, here's sclerosed or an obliterated capillary. Of course, both of them say that it's a focal segmental glomerulosclerosis, but maybe the first serial, the glomerulus appeared normal, but after 10 serials or 15 or 20 serials, we will see another one which shows the segmentally sclerosed segment in the same glomerulus that appeared normal in the first one. So multiple serial sections is essential in nephropathology. For EM, we should know that if we select at one or two glomeruli for the final ultrastructural or or electron microscopic examination for each case. So we select a normal or the least affected glomerulus for this examination. We cannot examine a globally sclerosed glomerulus or an extensively segmentally sclerosed glomerulus. It should be normal or the least affected glomerulus. Otherwise, it will shows us many fallacies, and we will see later on. And we should be cautious about the clues that denote that there is a possibility for an unsampled focal segmental glomerulosclerosis in any biopsy, especially in smaller biopsies. These clues include what? Unexplained IFTA or unexplained interstitial fibrosis or tubular atrophy, where all glomeruli are normal in the received biopsy, but there's an interstitial fibrosis of tubular atrophy. It shouldn't be there. This means that there is something that is not sampled. There is a focal segmental glomerulosclerosis that could be unsampled. Hypertrophy or an increase of the normal appearing glomerulus. As we have said, that glomerular hypertrophy is the first step in developing focal segmental glomerulosclerosis. So a big glomerulus that is more than 40 high power field in size under a light microscope. This is for pathologists. This means this glomerulus is hypertrophic or big. So unexplained IFTA in normal plus normal glomeruli, like this picture, this circle shows us what? Can anyone describe this? No one like to describe it?
You can answer in the chat. We have polymorphs,
No.
increase mesangial matrix.
Okay.
No,
No, we
this
need.
this is an old message. We have now polymorph, interstitial fibrosis.
Okay. And
Interstitial
tubular atrophy.
fibrosis, yes, and tubular atrophy, yes.
And tubular atrophy. Okay. This is a low power magnification, low magnification power for a core biopsy. And no glomeruli appear in this picture, just only tubules. And these are cortical tubules because they are back to back. And if you compare these tubules with these tubules, you can see that these tubules are of smaller diameter, thicker tubular basement membrane, and separated from each other. So this is an area of interstitial fibrosis and tubular atrophy. Otherwise, the glomeruli for this biopsy were normal. So this is an unexplained interstitial fibrosis of tubular atrophy, which will raise the suspicion for the presence of an unsampled focal segmental glomerulosclerosis. We should know that focal segmental glomerulosclerosis is a very focal process that could be missed or unsampled even in adequate biopsies, and is missed more in biopsies that include less than 25 glomes. In a minimal change disease on the other end of the spectrum, don't worry about. So as we worry about unsampled focal segmental glomerulosclerosis, we need to unworry about something in a report of minimal change disease. What we don't need to worry about in this report is in a middle-aged or elderly patient, we could find mild vascular lesions as arteriosclerosis or arteriolar hyalinosis, focal non-specific interstitial fibrosis. This could be secondary to hypertension or any other non-related disease, and globally, but not segmentally sclerosed glomeruli. And we should be aware about the difference of having some globally sclerosed glomeruli, whatever the age of the patient is. This has an equation that we can calculate what is a percentage of a normal globally sclerosed glomeruli that can be present, which is half patient's age, half of the patient's age minus 10. Then this is a normal wear and tear process that we can find global but not segmental sclerosis. So it's normal or could be accepted to find globally sclerosed glomeruli according to the age of the patient, but it's not accepted to find segmentally sclerosed glomeruli. So focal segmental glomerulosclerosis has two classifications: etiologic classification, which is very important, and morphologic classification, which loses its importance day after day. Morphologic classification, which is a TIB lesion, and that is known for its good prognosis. Very Heiler, that is was famous for being secondary to hypertension or obesity or something like that. A cellular variant and collapsing, that is known of being the worst prognosis, and NOS, which is none otherwise specified. And all of these classifications, with all what I have just said about what is these are famous of, do not denote an underlying etiology and differ in their prognosis and regarding their response to therapy and treatment. But on the other hand, the etiologic classification is very important for being a primary focal segmental glomerulosclerosis, secondary focal segmental glomerulosclerosis. Secondary, this includes what is adaptive, that secondary to obesity, which is I prefer to say give it the name of compensatory or adaptive focal segmental glomerulosclerosis, and secondary or sclerosing, secondary to sclerosis after an inflammatory region or immune-mediated disorder, and immune-mediated GN, and the genetic focal segmental glomerulosclerosis. All of these etiologic classification may share the same morphologic character. So primary focal segmental glomerulosclerosis can be TIB lesion, can be Berry-Heiler, can be cellular, can be NOS, any of these, and the other secondary and genetic FSGS. But all of these etiologic classification differ in management and prognosis, of course. So the morphologic classification, as we have said, have let us go through these in light microscopic pictures and see what this means. What is known as the tip lesion means that the tip, which is the tubule. So here we need to recognize where is our hilum and where is our tip. And this depends mainly on the cut, on the serial section where the cut is. The cut can detect this end, this hilar pore and tubular ball, or not. So if it's not presented in one of the serial cuts, it will be seen as an NOS, be termed the tip lesion. So by chance, this one, the serial cut, gives us this beautiful picture for this inlet, and this is the proximal convoluted tubule. It continues here with this outlet. Let's see, it's the outlet, and that's the tip with the glomerulus, the glomerular capillary that is here showed adhesions with this outlet. So it's a tip lesion with sclerosis at this adhesion at the tubular pool with sclerosis less than 25% of the glomerulus. Berry-Heiler means what? Means adhesions around the hilum of the glomerulus. As we have said, that suggests secondary FSGS. However, primary FSGS cannot be excluded, and this is important to be put in mind. The secondary focal segmental glomerulosclerosis, which could be perihilar or any other morphologic pattern, could be secondary to what? So could be secondary to reduced renal mass as segmental nephrectomy or glomerular hypertension, which could be secondary to abnormal glomerular growth and pressure due to low birth weight, unilateral renal agenesis, or cyanotic heart and sickle cell diseases. Also could be secondary to obesity, diabetes, and hypertension. All of these are causes of glomerular hyperfiltration and glomerular hypertrophy later on. The collapsing variant is known as being of a poor prognosis with non-response to steroids and rapid loss of renal functions with marked proteinuria, which is very important clue in the clinical data that we receive, because not, I should say that we could have partial collapse in focal segmental glomerulosclerosis and not totally collapsing features in a case. So it's not, I will not say that this is a collapsing focal segmental glomerulosclerosis unless it has the full picture with marked proteinuria and the full picture for the collapsing variant for this ominous term to give for a patient. And more of these patients are Africans. However, it's not uncommonly encountered in our population, especially in the era of COVID-19. An involvement of even one glomerulus with variant of focal segmental glomerulosclerosis equals classifying it as a collapsing focal segmental glomerulosclerosis. And let's present this case for a 37 years female with renal impairment and protein 7 grams with anemia, vomiting, and negative serology and negative virology. Her light microscopic picture showed 18 glomeruli, 7 of them globally sclerosed, 5 segmentally sclerosed with tuft collapse, and 5 with sclerosis NOS. So even if we have one glomerulus with a tuft collapse, in this biopsy, we will turn it collapsing and not NOS with the full-blown picture, as we have said, that it should be an heavy proteinuric patient. With another features for this variant of focal segmental glomerulosclerosis, which is florid epithelial hyperplasia with protein resorption droplets. And the tubules show severe injury, which is disappropriate for the sclerosis, and with microcystic changes, and interstitium showed diffuse moderate lymphoplasmacytic infiltrate on top of IFTA 20%. So this is a tubular injury with microcystic changes. One glomerulus normal and another one was globally collapsed with florid epithelial hyperplasia. That's an atrophic tubule, higher power for what we have seen previously. And let's see what is florid epithelial hyperplasia. Is the hyperplasia of the visceral podocytes. So it's a proliferation of the same type of cells. The nuclei, all of these nuclei are of the same features. No inflammatory cells in between. And these are the collapsed glomerular capillaries versus these patent capillaries. So these are collapsed and these are proliferating visceral under electron microscope. This is a collapsed glomerulus, the glomerular capillary with an overlying effaced podocytes.
Sarah, we have a question in the chat box. Can we have collapsing FSGS without clinical FSGS?
What is clinical FSGS?
I think Dr. Mu'min means without nephrotic syndrome and acute kidney injury and so on. Can we see in the biopsy?
That's what I was talking about. It will not. It is not a collapsing. A collapsing FSGS usually presents with not. There could be some cases. There could be a segmental it's not a collapse, it's just an obliteration of the glomerular capillaries without ovid hyperplasia of the overlying, florid hyperplasia of the overlying podocytes and the resorption droplets. The collapsing focal segmental glomerulosclerosis has a clinical picture that is could not be mistaken. Plus the light microscopic or the histopathologic picture. The focal collapsing features that could be seen in another variant of focal segmental glomerulosclerosis does not mean that this is a collapsing FSGS.
Okay,
Am I clear?
yes, we have a question from Dr. Abdullah. Collapsing mimic crescent. I can reformat the
Collapsing
question. Yes, I will reformat the question. How to
mm,
differentiate between
between
pseudo
real
crescent
crescent
and
and
true
pseudo
crescent?
crescent.
Yes,
Mm.
morphologically.
The main difference between pseudocrescent and a true crescent is the presence of other components. What are other components? The inflammatory cells, the fibrin, deposits or the fibrin component in the crescent for the true crescent, but in the pseudocrescent, only one type of cells, one type of nuclei. If we can see here, all of these nuclei are the same, similar, no difference. If we can wait for the coming slides, we will see a true crescent. Just put in mind that the pseudocrescent are formed of one type, single type of nuclei, which are the visceral podocytes, the large nuclei. These are large nuclei, okay? And no neutrophils, no inflammatory cells, no monocytes, no fibrin, just these nuclei, okay? Let's continue.
Okay.
What's the etiology of collapsing FSGS is not fully defined till now. Some evidence suggests that the excess incidence of collapsing FSGS in African Americans is linked to APOL or apolipoprotein 1 gene. It could be viral agent, as we have seen in COVID-19 and HIV nephropathies. Could be parvovirus, which is proposed to be associated with more than HIV, and severe vascular injury. Let's know that severe vascular injury could lead to collapse of the tuft. So it's not always a collapsing glomerulus means that this is a collapsing FSGS. Collapsing glomerulopathy can also occur secondary to drugs as the CNIs response, and this can occur de novo without a previous collapsing FSGS. A collapsing FSGS has been reported to recur also in renal transplants, but it can occur secondary to CNIs, interferon therapy, and bamidronate toxicity. Should be mentioned that in adults, visceral epithelial cells, both sides are terminally differentiated cells and are unable to proliferate. So normally they are unable to proliferate. These podocytes are unable to proliferate. What makes these cells proliferate is an injury. Let's see this picture for an infantile glomerulus, infantile looking glomerulus. This is an infantile looking glomerulus. This is for a case, this was a case of a 9-year-old male and proved to be Albert under light microscope. His under, sorry, electron microscope. His light microscope showed I think he had about 4 glomeruli out of 12 with this looking. This is an infantile looking glomerulus, which is not normal for this age to have this percentage of these infantile looking glomeruli. This is another one with microcystic expansion or microcystic tuft, microcystic Bowman capsule with this knot of glomerulus. These are what? All of these are podocytes. These are proliferating podocytes because this is an infantile glomerulus, not a normal appearing. Other pictures, we can just see just one podocyte here, one here, and not all this number of podocytes. Podocytes can not anymore proliferate. So, thus, the characteristic feature is a florid epithelial hyperplasia, which is either due to proliferation of parietal epithelial cells lining the Bowman capsule or re-entrance of the podocyte to the cell cycle and thus proliferate. This occurs in cases of HIV and nephropathies associated with collapsing FSGS with inhibition of the cyclin-dependent kinase inhibitors, which are normally highly expressed in podocytes. This florid epithelial hyperplasia makes what's called pseudo-crescent of collapsing FSGS, which should be differentiated from true crescents that could be present with different types of glomerulonephritis. However, differentiation could be difficult, and this should be known and put in mind that differentiation could be difficult. It's not all that easy. Let's see this picture for a case this was a patient of a systemic lupus with crescents. Can you appreciate here one type of cells or a mixture of cells here?
This is a mixture.
A mixture of cells. We can appreciate here. This is this is probably a proliferating podocyte with a large nucleus. And what is this?
Neutrophil.
We have mentioned it in the last lecture. This is a
Karyophytes.
neutrophil.
Neutrophils.
Neutrophil or karyophytes. This is a karyophytes. This is probably a neutrophil, and this is a destructed neutrophil that could be called karyophytes. This is another neutrophil, and this is another karyophytes, and another neutrophil, and another neutrophil. So all of this could be termed a mixture of cells. So this is a true crescent. This is a true crescent. The whole scenario here says that this is a true crescent. Okay. The mixture of cells, the case is a case of lupus, so it's a true crescent. Unlike if we remove these cells from the pictures, these small cells from the picture, and we just have these proliferating podocytes, it will be a pseudo crescent, but not in this case because it's a case of lupus. Okay. Is it clear? Have we answered the question?
Yes.
Regarding the difference between the true and pseudo crescent?
Yes.
Okay. It's a higher power for the same glomerulus. That's the inflammatory cells and neutrophils here, and these are the proliferating podocytes with the large nucleus. Okay, and again for the florid epithelial hyperplasia, just to compare. So again, focal segmental glomerulosclerosis is a light microscopic diagnosis or an EM diagnosis. What is the role of both in the focal segmental? Reporting focal segmental in a light microscopic report is just a description. It's not a diagnosis. Assessment of the extent of effacement, the percentage of the effaced podocytes with the presence or absence of immune complex deposits by immunohistochemistry or electron microscopy or both is essential to determine the underlying etiology for proper management. So, primary focal segmental glomerulosclerosis, which is probably or possibly due to circulating cytokines. By EM, we'll see diffuse effacement, and in these cases, response to immunosuppressives occurs usually. In secondary or adaptive focal segmental glomerulosclerosis, like maladaptive secondary to obesity or hypertension, in these cases, we will see segmental effacement, and these cases will be more resistant or non-responsive to immunosuppressives. Genetic FSGS with an inherited or a de novo or acquired genetic mutation, diffuse or segmental effacement could be present. So in genetic FSGS, diffuse effacement could be present and segmental effacement could be present as well, according to the mutant gene. According to the mutant gene, the extent of effacement occurs. So effacement less than 50% is called segmental, as in this case, we can see here podocytes are normal, but here podocytes are more effaced, here are widened, here effaced. So it's a segmental effacement. While here it's diffuse effacement, all podocytes are effaced. However, there is an overlap between primary or idiopathic focal segmental glomerulosclerosis and secondary or maladaptive focal segmental regarding extent of effacement. Extent than 50% strongly suggests secondary focal segmental. However, more than 50% could occur also in secondary focal segmental, but in a minority of cases. So the rule is more than 50% is more primary or genetic, and less than is more with maladaptive focal segmental glomerulosclerosis. Okay, other causes of glomerulosclerosis other than focal segmental, as we have said that focal global and not segmental glomerulosclerosis could be related to age or secondary to arterial or vascular insults, and non-specific focal segmental or scarring secondary to immune-mediated GN could occur in post-inflammatory conditions. And I need to describe this picture. What is this picture? And what is the underlying etiology? This patient suffers from what? Can anyone describe the right side of the picture and of the glomerulus? I mean this side and this area with the circle around it. Can anyone describe it?
Please write
Is it
in the chat
difficult?
box. If you can comment on the mesangium, comment on the capillaries.
Can anyone comment on any compartment of the or any segment of this glomerulus? I can help if you need.
You can ask targeted
What about
questions, Sarah.
okay. What about this glomerular basement membrane? Is it normal or a little bit or markedly thickened? Is it thickened or there is deposits? These capillaries are patent or occluded? This stuff shows adhesions or not?
The answer is a thickened glomerular membrane.
Okay, it is thickened by deposits. That's the wire looping of lupus.
Yes.
It's a sign of activity of lupus nephritis. So this side shows an active lupus, and this side shows what? Shows obliterated glomerular capillaries with adhesions to the Bowman capsule. So it's a scarring. It's a focal segmental glomerulosclerosis, the glomerulus. Half of it active and half of it chronic. For the same patient in the same glomerulus. So this is a post-inflammatory scarring. Okay. Thus, proper classification is essential for proper management for focal segmental glomerulosclerosis, and we should probably proper clinically evaluating the cases with light microscopic or EM pictures, and first as a first step, and then differentiate between what is the type of the deposited complexes, if any is present in the case, and genetic studies if needed. So let's have a scenario for an obese patient with focal segmental glomerulosclerosis under light microscope. And this patient was improperly investigated. I mean that proteinuria was not quantitatively assessed, and he's just obese with proteinuria and had light microscopic examination only. And this patient was considered as secondary or maladaptive obese-related focal segmental glomerulosclerosis, and only supportive treatment for for weight reduction and ACE inhibitors were given to him, and deterioration of renal functions occurred. Another scenario for the same patient is the quantitative assessment of proteinuria with EM. The patient had nephrotic range of proteinuria with diffuse effacement and a full picture of nephrotic syndrome, as light microscope picture showed FSGS and diffuse effacement for diffuse effacement under electron microscope, and this suspect primary focal segmental glomerulosclerosis, because as we have said that diffuse effacement could occur only also in genetic focal segmental glomerulosclerosis, and he started immunosuppressive therapies and was responding. So this obese patient had the primary focal segmental glomerulosclerosis, not maladaptive or adaptive focal segmental glomerulosclerosis. If he is resistant, this time this diffuse effacement could be secondary to gene mutation for vital genes that can lead to diffuse effacement as well, like nephrin gene. Okay, another case for a nephrotic adult focal segmental glomerulosclerosis under light microscope, and no family history and no secondary causes, so is not obese, not hypertensive, and again not properly investigated, and considered as being a primary focal segmental glomerulosclerosis, as there is no family history and no secondary causes. And he received steroids with no response, plus the steroid side effects. When he had an EM and segmental effacement was seen, where here the podocytes are preserved with this segment with more effaced podocytes in the other side. This denotes that focal segmental or primary focal segmental glomerulosclerosis need to be excluded, and genetic testing for a less vital gene like actin-4 could be present with a less role for immunosuppressors. Here I need to say two things. The first thing is what this patient had a history of steroid intake before the biopsy that was processed for EM. So this means that if this patient responded even partially for the steroids, effacement could regress and could present as being segmental because of the effect of steroids, because steroids have an effect on the cytoskeleton of podocytes, and this makes a role for immunosuppressive therapies, even in cases not only in cases of primary focal segmental glomerulosclerosis, but even for cases of genetic focal segmental glomerulosclerosis, because of its affection of the steroid affection on the cytoskeleton of the podocytes. This point is clear, Dr. Muhammad?
Yes, clear, totally clear.
Okay. I just need to say this point, and will be declared more in another case.
They are asking you in the chat to repeat it again.
I repeat it again
Oh,
with a case.
okay.
Okay. If a patient, another case scenario, with a subnephrotic range of proteinuria with segmental effacement plus light microscope showing focal segmental glomerulosclerosis, with obesity and hypertension, and he's subnephrotic, this is mostly what adaptive focal segmental glomerulosclerosis or compensatory, and supportive kidney treatment with ACE inhibitors and weight reduction and good for this patient with no obesity or hypertension, and genetic testing for the segmental effacement of podocytes has less role. And as I said, it's not a no role of for immunosuppressives, is less role for immunosuppressives. Other case scenario is either the patient has a nephrotic or subnephrotic proteinuria with effacement diffuse or segmental, but he has electron dense deposits. This means that it's a post glomerulonephritis scarring. It's not a focal segmental glomerulosclerosis, which is under the umbrella of podocytopathies. It's a post glomerular scarring. Let's see this case for the role of EM in monitoring the effect of therapies, and what I was talking about, the effect of steroids on podocyte cytoskeleton. I was talking about, we all know that primary focal segmental glomerulosclerosis or minimal change disease, the main line of therapies in these cases is steroids as a first line. And for me, myself, I saw that there is no role for steroids in cases of secondary focal segmental glomerulosclerosis because it's not a primary, it's not a primary case, it's secondary. But I found, and some of my colleagues told me that no, we use steroids, but with lower doses. Why? Because steroids have an effect on the cytoskeleton of podocytes. What is a cytoskeleton? It's the building units of the cytoplasm molecularly. The building molecular like actin and keratin that makes the morphology of the podocytes like to be like these food processes, and these are this cytoskeleton cause the change in its morphology from being like these podocytes, finger-like podocytes, or loses its morphology, becomes effaced. So the steroids affect this cytoskeleton, and this issue needs to be more studied to learn more about the effect of steroids in these cases, and what is the proper dose to use in these cases, the primary focal segmental and the secondary focal segmental glomerulosclerosis, or the genetic focal segmental glomerulosclerosis. So this is a case of a nephrotic female, 17 years old, and was thought to be minimal change disease, and she had a biopsy. Her EM was like that. It's almost normal, not effaced, but this small segment and this one. The rest of podocytes are totally normal. So it's not a minimal change disease. And we had no history regarding this female, just nephrotic and no other clinical data. When we returned it back to our colleagues and asked what about these females, they said that the biopsy was done 15 days after starting immunosuppressives. So it's a resolving podocytopathy. This is the resolve of effacement and the effect of steroids. So after being totally effaced with loss of the finger-like projections of podocytes, they will return back again to be finger-like processes, and normal, and clinically will reflect by resolve of proteinuria.
We have a question, Sarah. For how long corticosteroids needed to give an effect on podocytes? I think that there is no clear period, right?
I think no clear question, and this is this patient. It was just by luck
Yes.
that they had the biopsy, and the patient did well under steroids, and we had the biopsy, and just by luck. So what's the needed time? We don't know.
That's why we have a rule in nephrology: don't start immunosuppression in any case once biopsy is indicated, except if there is life-threatening condition like rapidly progressive glomerulonephritis or complications from nephrotic syndrome. If the case is indicated for biopsy and there is no life-threatening condition to start immunosuppression, just start general supportive treatment till you do the biopsy because immunosuppressions can change the pathology. We have another
That's right.
Yes, we have another question. Can we use CNI or steroids in non-primary FSGS for its antiproteinuric effect? I think no, we don't. We must not use immunosuppressions for genetic or secondary FSGS because usually they have subnephrotic range proteinuria that can be easily controlled by general supportive treatment. Secondary and genetic FSGS are not indicated for the use of immunosuppressions. Do you agree, Sarah, or you have another comment?
Uh, I think I am not fully qualified to agree or disagree on the role of steroids in these cases, but that's what I searched on. I saw that it has total no role to give a patient with genetic FSGS steroids. But
Yes.
I found that some of our nephrologists use it it's not the same dose as the primary, of course, the primary focal segmental. But when I asked why, they said because it has a minor role and it reduces proteinuria somehow. When I had tried to know to search in the literature, I found that there is some evidence about its role on the cytoskeleton of podocytes. But what is the dose cost benefit regarding the
No,
uh,
by evidence and by guidelines,
mm,
immunosuppressions has no role in genetic and secondary
mm,
FSGS.
mm,
Theoretically, yes, it may have an
mm,
effect, but clinically
mm,
applied, it has no effect. There is new
mm,
evidence that some genetic abnormalities in FSGS may respond to steroids, but this is not approved 100%. So by
I think
guidelines,
that the side effects may be more aggressive than its benefit in these
yes.
cases.
And steroid resistance is
I
very
think yes.
common in genetic conditions with
Mm,
toxicity from
mm.
immunosuppressions. The only way, the only,
If mm,
yes,
mm,
yes, as
اتفضل.
you mentioned, yes. So there is no rule for them.
Mm. If I have the right to agree or disagree, I agree with no rule for steroids. I agree with this completely because, but I'm talking actually from the theoretical or the ultrastructural point of view. It has an effect on the cytoskeleton of podocytes. But the side effects may precede this effect, of course, and maybe at the last of the day, the patient with all system affection, not only the podocytes, of course.
Okay.
Okay, let's continue. Sometimes we should know that sometimes immune deposits may appear by EM and not by immuno, and vice versa, especially with the segmentally sclerosed cases. So that's why we may need to do both modalities by rule. We need to do immunohistochemistry and electron microscopy and light microscopic examination for all cases, but sometimes financially we cannot. But also sometimes, although there's financial issues, but we need to do both because with extensive segmental sclerosis, so many non-specific deposits could be present by immunohistochemistry rather than immunofluorescence, and EM could support the diagnosis in the final report. We should mention that extensive food process effacement, more than 50% of the glomerular basement membrane surface area, is typical in both minimal change disease and primary focal segmental glomerulosclerosis. So EM does not differentiate between focal segmental glomerulosclerosis or primary focal segmental glomerulosclerosis and minimal change disease. What I mean, in another word, is that if we have a light microscope, it's a no change under light microscope. Some of our colleagues think that if we proceeded for an electron microscope, we can exclude focal segmental glomerulosclerosis or primary focal segmental glomerulosclerosis by electron microscope. No, electron microscope in minimal change disease and primary focal segmental glomerulosclerosis will show us diffuse effacement. In both cases, we should see a segmentally sclerosed glomerulus in light microscope, under light microscope, to say that it is afocal segmental glomerulosclerosis. Okay? Is it clear? This point need to be clear in our minds, especially in our the mind of our junior colleagues. Electron microscope does not differentiate between minimal change disease and primary focal segmental glomerulosclerosis regarding the extent of effacement. Increase in mesangial matrix under electron microscope could be seen as these circles. These are an increase in mesangial matrix or increase in matrix that causes obliteration of the glomerular capillaries. This is the normal mesangium. If you compare it with this expanded matrix. In primary focal segmental glomerulosclerosis, no immune complex deposits, but hyaline deposits could be present, resulting from the endothelial injuries in sudation of the plasma protein and will be present mostly in the vascular pool. That's what I was talking about, the non-specific deposits or hyalinosis in sclerosed segment. This is an electron microscopic picture, and these are the knife marks, our lovely knife marks. If I can tell you, Dr. Mohammed, the knives that we use for ultra thin sections of the electron microscope are diamond knives. Okay, these diamond knives are very expensive. Let's not mention the price here, but are very expensive. So when it starts to have cracks like that, it makes these knife marks. And by the way, you can publish papers with these knife marks because it's not or oftenly present in electron microscopic pictures. Back to what we were talking about, the non-specific deposits or hyalinosis. So these are non-specific deposits because this is a sclerosed segment of a glomerulus with these non-specific deposits or hyalinosis. So not all what is dark is a specific deposit in under the electron microscope. The rest of the lecture will talk about focal segmental glomerulosclerosis after renal transplantation. Primary versus secondary focal segmental regarding the rate or percentage of recurrence. Primary focal segmental glomerulosclerosis recurs more than secondary. That's why we need to diagnose it for these patients before they go to renal transplant. Usually, primary recurs after transplantation. However, it may recur after months or years after transplantation, while secondary and genetic uncommonly recur. Thus, accurate distinction between them is very important. A study done by and published in the Journal of American Society of Nephrology in 2020 mentions that idiopathic or primary focal segmental glomerulosclerosis recurs in about 32% of patients, with subsequent graft failure in 39%. The incidence of recurrence reached to up to 80 to 100% in second renal transplant if the first graft was lost due to recurrence of primary focal segmental glomerulosclerosis. The accurate distinction is challenging, particularly if the ultrastructural evaluation of the kidney is missed or the genetic testing is missed. Some points predict the risk of recurrence. The pathological point in these points is the mesangial proliferation pattern in podocytopathy. Sometimes, in case of podocytopathies, we may find a mesangial expansion with proliferation with no deposits, of course. This was mentioned as a point that may predict recurrence. Management is a plasmapheresis of recurrent, in cases of recurrent focal segmental, is the results in complete or partial remission, as you know better than me. And we will have some talk about this plasmapheresis and its effect on biopsies, as what Dr. Muhammad mentioned about the effect of steroids on the biopsy. Proteinuria, what's important here is that we should know that proteinuria may develop immediately after the graft implantation, and EM shows effacement at the time of recurrence, and this precedes the development of sclerosis, typically by weeks to months. So during the time or this time interval where the patient is proteinuric, focal segmental glomerulosclerosis patient with a renal transplant is proteinuric post-transplantation. Diffuse effacement under EM alone without segmental sclerosis in light microscope is an evidence of recurrent focal segmental glomerulosclerosis with a known primary, before being transplanted. This is a patient of primary focal segmental glomerulosclerosis. Post-transplantation, 1 week post-transplantation, he developed proteinuria. His minimal change disease, yes or no? Can anyone answer?
Please answer in the chat. No, they are saying no.
No, he's a patient of a recurring focal segmental glomerulosclerosis. And let's describe this case. 12 years old female, known focal segmental glomerulosclerosis, and 12 days post-renal transplant, she developed proteinuria that increased from 400 milligrams to 1 gram 800 and serum creat of 0.8. The patient received 2 sessions of plasmapheresis, one before and one after transplantation. The renal biopsy was done 2 days after the sessions of plasmapheresis. So she received plasmapheresis and then the biopsy was done. Under light microscope, everything was normal, no change under light microscope. Under electron microscope, just a single glomerulus showed segmental effacement 15% with microvillus transformation, and rest of the examination was unremarkable. There were no electron dense deposits. So the effacement here is just segmental, very minimal. It's not diffuse effacement. This is the area of effacement. And here just broadened. Here it's totally normal. So it's not the scenario that we were looking for. We were looking for diffuse effacement because the proteinuria recurred in a known patient of primary focal segmental glomerulosclerosis. The electron microscopic picture here is of podocytopathy, but it's not the the diffuse effacement that we were hoping to find. In the light of the clinical data, as well as the electron microscopic examination, this focal segmental glomerulosclerosis is either recurring, where effacement will increase later on, or resolving. It could be resolving as an effect of plasmapheresis, and I think that this is the more probable, that's the more convincing probability, as the plasmapheresis had some effect. So we noted in the presented case of recurring focal segmental that effacement was segmental, unexpected for a recurrence of primary focal segmental. This could be due to very early biopsy, could be. However, effacement, diffuse effacement could occur at this time. And this could also be the early post-transplantation sessions of plasmapheresis, which would regress the progression of effacement and focal segmental glomerulosclerosis. And again, this observation need further studies and patients follow-up. Another item we could highlight is the difference between the primary focal segmental and the arterionephrosclerosis. Arterial by light microscope, extensive vascular sclerosis will be found with glomerular fibrosis around non-sclerotic glomeruli as an ischemic changes, and by EM we will see something with like the increase in the lamina rara interna that we have described in the first lecture. So here, this is a vessel with this increase in the or arteriosclerosis increase in the intima is intimal thickening, and this glomerulus showed somehow ischemic changes with the thickening of the Bowman capsule. Again, Mason trichromes showing this thick intima with widening of the lamina rara interna, which is the injury of endothelium secondary to hypertension. It's a hypertensive patient with expansion of what is known as the lamina rara interna in this case secondary to the arterionephrosclerosis. And this is a case of 17 years old female with AC ratio of 7 grams, negative immune profile and negative virology with focal segmental glomerulosclerosis perihilar, diffuse effacement under light microscope with microvillus transformation and detached podocytes with widening of the lamina rara interna. And today I'm just showing you some interesting findings that we have found during our routine examination in some of our cases, like this case. It's a straightforward focal segmental glomerulosclerosis with this hilar, this is hilar inlet, Dr. Muhammad, with widening with perihilar sclerosis. And here light microscope showed diffuse effacement, diffuse effacement, diffuse effacement with detached of podocytes. Here we can appreciate widening of her lamina rara interna, maybe secondary to an hypertension episodes that could occur in this case of focal segmental glomerulosclerosis, where here's hair lumen and podocytes here, and maybe this is segmental injury of podocytes, and these are the floating fibrin tactoids that could occur, could be found or should be found in the cases of formed thrombi here, but the endothelial injuries that may occur secondary to hypertension that probably occur in this case of nephrotic syndrome end up with formed thrombus, but it was an incidental finding with these fragments of RBCs. Again, these tectoids. And this was not mentioned in the diagnosis. Of course, it's a focal segmental glomerulosclerosis perihilar subtype, primary versus genetic, as we have said. And this is for genetic confirmation. And thank you.
Thank you, Sarah, for this actually clinically applied lecture. And you highlighted a many important points that we have to consider while we are clinically approaching our patients. If there is any questions, dear colleagues, please write in the chat box so I can read to Sarah. But I think you asked most of your questions in the during the session itself. May I ask you last question, Sarah, before we close the session? I always
Yes.
have a problem with the terminology focal segmental glomerulosclerosis because as I see that not all lesions of FSGS are segmental. For example, collapsing FSGS, sometimes the collapse is not segmental, it is a global,
Mm.
right?
Global, yes. Mm.
So it is not an accurate term, right?
I think only in collapsing variant it could be globally collapsing
Yes.
or segmentally collapsed tuft. But the rest of patterns, which are more frequent in the presented cases,
Mm.
if we're talking about percentage, no, it's an accurate term because it's segmental.
Yes.
It should be segmental.
So,
Just the collapsing.
so
Mm,
if you found a globally collapsed sclerotic glomerulus, you
mm,
in your report you mention it is
mm,
a collapsing
mm.
FSGS or a globally
No,
collapsed.
no. I will not mention it as a collapsing FSGS, except if it is clinically and the whole picture of all the slides and the whole scenario is with collapsing FSGS, because as we have said that a collapse, segmental or partial collapse could occur secondary to a vascular event.
Mm.
Just a ischemic event cause ischemia, the tuft of glomeruli causes shrunken tufts. And in any ischemic insult, as we have said, can cause a collapse of the tuft. So it could be a vascular event. It's not always a collapsing FSGS.
Okay.
Collapsing FSGS has a clinical presentation, as you said, Dr. Muhammad.
So that answered the question that was asked before
Mm,
by Dr.
mm,
Mu'min. Can we have
mm.
collapsing FSCS without clinical FSCS? So we can have
I
a
think no.
collapse.
I think
Yes.
no, no.
Okay.
It should be complementary to each other. We should talk together about these scenarios is about the extent of proteinuria quantitatively, the renal functions, the acute onset.
Mm.
Uh, mm,
Okay. Thank you, Sarah,
Thank
uh,
you.
again for this nice lecture. And thank you all for your attendance. And see you next month, inshallah, with episode 4. Wait for the
Inshallah.
announcement, inshallah. Good night.
Inshallah.